Good morning, everyone. Good afternoon. My name is Robert Hamilton, co-founder and chief scientific officer of Novus Signal. It is my pleasure today to introduce the next installment of the webinar series by Dr. John Volpe, titled New Strategies for an Old Problem, Advances in the Treatment and Pathways for PFO. Dr. Volpe is a co-director of the Eddie Sherlock Stroke Center at Houston Methodist and associate professor of clinical neurology at the Institute of Academic Medicine. His research interests span a number of different critical areas of neurological illness, including ischemic stroke, intracerebral hemorrhage, epilepsy, and neurological infections. Of note, Dr. Volpe and his team, Dr. Volpe was a site PI of the recent BUBL study and the lead enroller at Houston Methodist that was recently presented at the International Stroke Conference. If there are any questions, please leave them in the chat box for further discussion following the presentation. And with that, I'd like to turn it over to Dr. Volpe for his presentation today. Thank you.
Thank you, Robert. I'm going to go ahead and share my screen here. All right, is everybody seeing one centered slide there? I'll assume yes. Let me just move.
We do.
Okay, great. Well, welcome everyone, and thank you again for having me, and thank you for taking your time to be with me at this webinar today. I really do think that if we had a conversation about what's new in PFO or what's out there in PFO 6 months ago, I would have been scratching my head a little bit. It had been a field that had evolved rather rapidly with treatment options, but we were still stuck with some, I think, lingering questions about diagnosis, and then the BUBL study happened, and we're going to talk about what that means and how that affected our new advances here and new strategies. But I really think that taken together with additional information from studies on population health and how they are informing our decisions, there's a lot that's new with PFO just over the last several months. So I'm going to share that with you, and I hope that we have plenty of time at the end to have some conversation on questions. I do have some backup information if we have extra time, but really want to get out there and talk about probably the number one thing I get asked, which is what is your approach to diagnosis? What's your approach to your algorithm for finding a PFO patient to close? So we'll go through that. And let's see if my slide, there we go. So that will be kind of part one of this presentation. Part two is going to be looking at some of those advanced population statistics and what they're telling us about outcomes and how to kind of shape that conversation when you have a patient who's PFO positive, and determining whether the right scientific balanced approach to treating that patient should be, and introducing what will probably be a rather new algorithm there for some of you all. And then the last one is talking just about the economics a bit, just a short conversation about how important this treatment is for patients who have stroke and preventing another stroke because of the place they are in their life, and how important that is to their economic output and all of us who care about stewardship of resources. So when we talk about that patient who presents with a stroke, and you may be seeing them in the hospital, or maybe even more often you're seeing them in the clinic after they've been hospitalized and are coming to you for additional input on their treatment, I really think that there's kind of a three-step process for evaluation of stroke. There's no one size fits all, but this is the basic algorithm I use when I'm talking to a patient, when I'm looking through the records, and when we're deciding what to do. And that's to make a tissue-based diagnosis, to really look at the imaging, analyze the imaging, and come up with a tissue-based diagnosis of whether it was a stroke or not. Then to look at the vessels and to get a sense of whether this was a vascular stenosis or other vascular problem. And if not, then to look for the other likely cause, which would be an embolic source. Before going too far into this, I just want to make a little bit of an aside about nomenclature, and there've been publications now about this, and I think the field has moved away from this term cryptogenic stroke. Unfortunately, we're stuck a little bit with it on some FDA labeling, but the idea that a stroke is of uncertain cause or unknown cause, certainly we can call that a cryptogenic stroke. But if you think it's from an embolic cause, we're moving towards this embolic stroke of undetermined source, or ESIS, if you want to say it that way. And even further saying that if we think something is PFO related, we're not really calling that a cryptogenic stroke anymore. PFO related embolic stroke would be the nomenclature that I would favor. So when we start with that patient who has imaging, ideally you want to see an MRI. Most all of our patients can get MRIs, even the patients who have pacemakers. They may not be in this population in particular, but even they can get MRIs pretty routinely now. And if an MRI is negative, if we don't see a stroke, generally that's the patient you want to proceed to medical management only. We're looking for stroke patient population for PFO closure. Overwhelmingly, that's the most important thing. And so I'll just show that's what the diffusion weighted lesion would look like on a MRI. There are a few caveats I'll put in. I said we're looking for most of the time, maybe 90+% of the time we're looking for that. If the patient was treated with TPA, or if the patient had a clot retrieval and you know for sure that that patient had a clot, well, that's good enough. We don't necessarily have to see a diffusion weighted abnormality if they had an intervention that kept them from having a stroke. In fact, we would call that an averted stroke. That's the terminology we prefer. That would be one of those exceptions to the rule. The other exception, or the other common scenario, is TIA. And really a TIA is not sufficient. It's generally not someone that you would go down the road of PFO closure. I'll talk a little bit more about that if we have a question about that. But the studies that were positive were based on MRI being positive. So then once you have that positive MRI, the next question is, what was the cause? So does the tissue suggest a chronic small vessel disease? Is this atherosclerosis? Is the patient have risk factors and have signs that their risk factors causing vascular disease of the brain? And in fact, if so, you treat with medical management. And so this is, let's just say this is your diffusion weighted MRI on your patient. And these are two different kinds of flare sequences you would see on different patients. And if it's a pretty clean flare, which this patient A has, well, that's no small vessel disease, no atherosclerosis. And now I'm very concerned about an embolic etiology. On the other hand, this is a different patient's flare, and they've got these fluffy white periventricular kind of changes on their flare sequence, T2 hyperintensities. And well, this is, several silent events before they had this clinical event. And in that case, I'm much more likely to diagnose this patient with small vessel disease, atherosclerosis, and not embolism. The key point, though, is that an isolated acute infarct of any size, just because this is a small, deep infarct, does not mean it's small vessel disease. The reason I think we run into some confusion here is that this is sometimes called a lacunar infarct. And truly, lacunar infarct is an ambiguous term. It's not one that has a clear definition. What it could mean is small vessel disease, and then you would treat the patient as such. But if your radiologist is reading this as a lacunar infarct, simply meaning a small infarct, it very well could be a small embolism. It could be a transient embolism in a large artery. But I just want to emphasize in particular, this thalamic location is a very common location for embolic stroke because it's the tip of the basilar. That's the end artery supply, and where a clot could end and leave behind just a small infarct, but it is not small vessel disease. So if you come across that patient who has a positive MRI, and now you're wondering what vascular disease could have caused it, what vessel pathology could be involved. So you want some kind of vessel imaging. More often than not, it's CTA, maybe even on the first test when they hit the door. But if not, you may have an MRA or you may have a Doppler, cervical carotid Doppler. And then you're asking, is there stenosis? Is there significant atherosclerosis? Well, then that's the cause, and you can pretty much proceed to medical management in those patients. Keep in mind, other conditions may produce multiple infarcts. You can have dissection that leads to emboli. You can have this spasm condition, reversible cerebral vasoconstriction syndrome. You can have vasculopathy, moya, or you can have microangiopathic disease such as TTP or sickle cell disease and vasculitis. All of those often have multiple regions of ischemia. I think this is, again, one of the myths that we hear is that embolic stroke has to be in multiple vascular territories when it occurs. It usually is not. Most emboli are in one single vessel when they occur. And if anything, it's these conditions that will sometimes look more diffuse in their ischemic patterns than you would see with an embolic stroke. So if you find no vessel stenosis, no atherosclerosis of the large arteries, no vasculopathy, no dissection, then really we're moving emboli up as the top concern. And when emboli are the main concern, I wish I could tell you this is the one approach to take, but really the first step I always say after that is thinking about the patient's medical conditions. So if this patient has, sick, if they have cancer, if they have liver disease, if they have chronic heart failure, if they've had DVTs and PEs, then there's all kinds of areas of emboli that I'm concerned about. And you want to have some kind of cardiac testing at that point. And most patients will have a transthoracic echo as their first line imaging. And there'll also be a concern about rhythm, whether this was atrial fibrillation as the cause, and those kinds of workups, which we'll talk about here in just a second. But in general, if you have a patient that's not really sick and is coming in without a significant medical history, and you have a patient that doesn't have much on their EKG, they have essentially a normal EKG, that is a strong predictor that you're dealing with a PFO etiology, and that should be kind of the main focus of ongoing workup. The area where I think we get a lot of questions then is, what about AFib? What about this occult atrial fibrillation? How do I know I'm not missing AFib? And to address that, I want to go to the table one of the two kind of trials that I think are relevant here. So if you're doing loop recorders, if you're familiar with the loop recorder data, you're familiar with the study called Crystal AF that was really looking at the kind of, again, the cryptogenic terminology, AFib clinical study, putting in these loop recorders, following the patient over time. Interestingly, there was a second study called Stroke AF, and that Stroke AF study looked at patients of known cause. So both known and unknown causes have these AF studies, and they actually had very nearly identical results. But I want to compare those AF studies to the REDUCE trial. So the REDUCE trial was the most significantly positive PFO closure study. And if we look at the baseline characteristics between these patients who were being looked at for AFib versus those who are in the PFO, the first striking difference is the age. The patients in the REDUCE trial were averaging about 45 versus in the AF about 61. And then if you just kind of go down at the vascular risk factors, hypertension, smoking, diabetes, and compare those, you can see there's a striking difference between the vascular risk factors you're seeing in the PFO closure study versus the Crystal AF study. So don't really think of these as two sides of the same coin. The patient who comes in with an embolic stroke of undetermined source who's 60 with risk factors deserves to have evaluation for AF. The patient who comes in their mid 40s without risk factors or younger, or maybe older without risk factors, you really want to be thinking more of PFO. The detection rate also is about 10% in the Crystal AF population. So again, most of those patients, the vast majority, won't have AFib. And that, just to remind ourselves, the incidence of AFib in the population of patients under 60 is below 0.7%, and even the even younger patients, it's lower than that. So taking one more sidestep into the stroke AF, what should we do about looking for it if we're going to do that? If you're on the fence, if you've got that patient who's somewhere in between, you're not sure if you should look, how long you should look. I think the way I've answered that is really about outcomes. So you can certainly see that these are detection rates between an implantable cardiac monitor and a non-implantable cardiac monitor control group. And you'll find more detection of AFib in the cardiac monitor. But the outcome in terms of stroke recurrence, the difference between these two curves was really all within the first 30 days. And then the two lines are fairly parallel. So if you wish to have the most evidence-based, not missing a stroke risk, this is where I think you get your bang for your buck, is in the first 30 days. So doing a 30-day heart monitor, making sure the patient doesn't have AFib, I think is very reasonable if you feel that they're in that higher risk for AFib going on with that patient population. So again, kind of keep it simple. This is how I approach it. Do I do a loop recorder? Yes, if the patient's over 60. Yes, if they have multiple risk factors. Yes, if they have a sick heart with an abnormal left atrium. But no, if they're 59 and under without typical risk factors. No, if they've got a normal echo, normal EKG, and no family history. Those would all be patients in whom I would generally not recommend a loop recorder. Again, I think are there exceptions to every rule? Probably the one other exception I would throw in there is alcohol. An alcoholic patient who has heavy alcohol use, you might consider them as being at risk even without other risk factors. So moving from the baseline demographics to actually looking for a shunt, when we do our PFO diagnosis, we need to ask the question, what's the most precise modality and diagnostic algorithm for detecting a PFO? And shunt size, grading shunt size. Does the grade of the shunt matter in the clinical risk reduction? In other words, should you be more likely to close a large PFO or a small PFO? And this is a very interesting question, and my answer has changed over the last several months. So the detection options, you can of course do the TTE, you can get the TEE, you can do a transcranial Doppler with BUBL. You may consider cardiac MRI, or you may even consider an intracardiac echo, which is a catheter-based procedure. But the one I want to, of course, discuss in details is the BUBL study. And here we see the first generation, the generation that was used to study patients in the BUBL study of the robotic-assisted transcranial Doppler. And I'm sure everyone attending today has heard of or seen it, but just in case you haven't, these are the probes. The probes are looking at the temporal windows, and the robotic device uses AI technology to find a window for the middle cerebral artery and insunates that window during the BUBL injection to determine if the patient has a positive right to left shunt. This is novel. This was a kind of a first of its kind device that was being tested. And the BUBL study is not published, so no surprise, most of you probably aren't familiar with the BUBL study, but it was presented in February of 2022 at International Stroke Conference, and it was a main event plenary session presentation. So what did we look at in the BUBL study? We looked at standard of care TTE as one comparison group. So these were patients who'd gone through a stroke workup, and there was at least a concern that they may have an embolic stroke. And so they had their TTE as a comparison, and they'd had a BUBL study with that TTE, and that was the control group. And then the question was whether the robotic assisted TCD compared differently in detection of PFO. So this was the comparator, was robotic associated TCD. 129 patients were enrolled. This was a diagnostic study, no therapeutic interventions, and the average age was 61. And this is this was the primary endpoint, looking at overall detection of right to left shunt. And again, we're going to call it right to left shunt because this is what TCD detects versus being able to be sure that it's a PFO. So the assumption was in patients who may have an embolic stroke as their cause, we think that about 50% of them have a right to left shunt. And that was the estimate of the baseline. But the results were that 64% were detected with robotic assisted TCD. So actually found more than expected from baseline data. But I think they're very not surprising to the investigators, maybe not surprising if you followed the literature, but the unfortunate result was TTE missed a significant number. It was positive in 21%, a large gap from what was expected in the baseline population, but 1/3 of what was actually found on TCD. So a significant under detection of right to left shunts on TTE was the main observation. And thank you to Mark Rubin for this data and NovaSignal as well for providing it. You may think when you hear this, especially if you're a cardiologist and you've seen TCD versus TTE versus TE in the past, well, what it's finding is shunts in the lungs. What it's finding is shunts that I can't close anyway. But that's not the case. And I will say that we did this at our center as well, and our echocardiographers would have given me the same feedback when I showed them this data. But we asked that question in the study as well. We said, how many of these are intervenable shunts? In other words, a high-grade shunt that you would go after and could close. And what we found is that the robotic assisted TCD actually found 27% positive for intervenable shunts, whereas TTE was positive in only 10%. So that means that TTE completely negative missed half of the intervenable shunts and underestimated nearly 2/3 of the cases. So you might have you may have a positive on TTE, but it may be a low grade, where in fact it was a high grade shunt. That's what we mean by underestimated here, but completely reported out negative in half of them. So in other words, the TTE had a 50% false negative rate for clinically relevant PFOs, which I think is the main takeaway point of the BUBL study. So what's the conclusion? Well, I'm just going to put it out there, what I believe. TCD is now the gold standard screening tool. This is the appropriate way to look for PFO in a patient whom you suspect an embolic stroke of undetermined source. And you may have that resource available in your hospital setting, and the patient may be able to get it. In our hospital, patients are kind of going in and out quicker than usual. They may not be able to get a TCD. So many of our patients are actually doing this post-hospitalization, and there may actually be a reason that that's helpful, because at that point they're more alert, they're more able to cooperate. There's just you have control over the technologist, the equipment, everything that you're doing, hopefully, so you know it's done to those standards. And really, the key here is to avoid the trap of a false negative TTE. If a TTE is positive, it's positive, great, if that's the first step. But if it's negative, it can't be the last step. There still needs to be an additional diagnostic approach to looking for PFO with TCD. TE is very important, of course. I'm not in any way dissuading anyone from checking TEEs. That gives that anatomical information. It verifies that a right to left shunt is a PFO, and it often can come after TCD. In fact, I don't even order TEs on PFO patients. I leave that to my cardiology colleagues, because I know that they also have strong feelings about operator dependence and things with TEE. So I let them kind of manage their timing and how they want the TE to be done. And really to kind of distinguish here between the diagnostic workup and the treatment plan. There may be patients in whom you find a PFO, and for whatever reason, the patient may have a personal preference about not having a device, and still you want to have the right diagnosis. So TE may not even be necessary in a small number of patients. So just keep in mind that there's a value to having a diagnosis, even if it's not necessarily a straightforward change in treatment. So moving from the diagnosis to patient selection, selection is critical because now we've diagnosed a PFO and now we've diagnosed maybe an embolic stroke of undetermined source, but we have to also make sure that the patients we're closing are the right patients. And we have to recognize that not all PFOs contribute to stroke risk. In fact, 20% of the population has a PFO, and only a small minority of those people will ever have a stroke. Um, so we really need a rational approach for discussing PFO and the risk of future events, and really what I think is a diagnostic conversation with patients. So this is how I like to visualize. I'm a visual person, what we're dealing with when we have patients who have unknown causes of stroke and come to us with a PFO as a probability of incidental findings. So if you have a condition that's unrelated to their stroke, that's simply there, it should be balanced in the two populations. And I'm just going to use the example of reflux. What if we look for reflux in our patients? We may find it in both groups equally. But if we look for something that is related, PFO is twice as likely in the cryptogenic stroke patient population. It's going to be there. But then there's this, and I don't know if you can see my cursor, there's this question about whether all of these individuals are related, whether the PFO is related, or some of them are like the other population, and it's simply incidental. And that's where having an approach to diagnosis becomes important, because if we simply close everyone, we may be over-closing PFOs. The ROPE study addressed this. It was now it's been out for almost 10 years, and used the Bayes theorem to derive an index saying what is the likelihood that the PFO is pathogenic, that the PFO was a contributing factor. And it looked at these typical vascular risk factors: age, hypertension, smoking, diabetes. So notice that hyperlipidemia is not on there. It seems that hyperlipidemia is equally represented in both patient populations. And with this database, they were able to derive what's called the ROPE index. And I took this picture straight out of MD Calc, so you can just type, ROPE PFO into your Google browser, and it will pop up with this this algorithm if you wish to discuss this with a patient. And often I just plug their information in with them sitting next to me, and we look at it. The more points you get, the more likely the PFO is contributing. So you'll notice that these are negatives. So that's the first, just to make sure that you're clicking negatives. If they don't have hypertension, if they don't have diabetes, then they get points. So what does it look like in terms of the table? Well, if you are in the greater than 5 on your ROPE score, 6 and above, the probability that the PFO contributed is more likely than anything else. So you end up with these more than 50%. If it's less than 5, 4 and 5 are kind of equivocal. It could be, 34 to 38% means it's a realistic risk, but not the most likely. And then if it's 3 or less, it's almost certainly not. The other thing you get from the ROPE score is the likelihood of recurrence. And you'll notice that these patients who are actually, unlikely that their PFO is the cause, actually have a higher risk of stroke recurrence because they have small vessel disease, because they're having additional small vessel infarcts at a higher rate, which is pretty much what we'd expect, versus PFO strokes average about 4% per year recurrence rate. So, and 4% is, sometimes people will say, well, this is a low event rate condition, but keep in mind, we're dealing with patients who have a relatively young age to start with. So this is a compound risk, like compound interest, and their recurrence risk is much higher than just 4%. It's going to be compounded. So even if you have just a 2% annual risk and you're 20, you'll have a 55% chance of a stroke by 60, just because there's so many years there between 20 and 60. And you can look at for yourself at how that compounds with a 2% annual risk. And even if the patient's on the low risk, which would be the 9s and the 10s, they still have a far greater chance of recurrent stroke than one should have between 20 and 60. So even though PFO is really more often a stroke of the early middle age, the 40 to 50-year-olds, it is nonetheless very important to detect those younger patients as well. So if you're kind of thinking about this rope score, if you've used the rope score, you may have noticed what it's missing, and so I just put it what is not in the rope score, and that's what really came to light in the last several months as well as an additional diagnostic tool here. And what's missing is the echo criteria. So there's nothing in rope that says, does the patient have a large shunt or an atrial septal aneurysm, which are generally and thought to be higher likelihood that the PFO is the cause. So if you and the abbreviations here are LS for large shunt and ASA for atrial septal aneurysm. So if you have echo criteria and you integrate that with the rope score, you get what's now the Pascal classification system. And I think this is actually a very powerful approach to choosing the right patients for closure. And you'll see the way it works here is that a high rope score, meaning highly likely that the patient had a PFO attributable stroke, is either absent or present, greater than or equal to 7, or does the patient have high risk PFO features, large shunt and or either one, absent or present. So if both are absent, if they're not a high risk rope score and they're not a high risk echo criteria, then it's unlikely that the PFO is related stroke. We'll skip the two middle ones and just say, of course, if both are present, if they have a high rope score and a high risk, then they're probable. But if they have only one, that puts them in the possible. So either a high rope score or high risk PFO features, or we'll put them in possible. And this is the key, I think, innovation of the Pascal classification system. And here's why. Because if we look at the hazard ratios, the actual way that these patients did over time in the clinical trials, we have, not surprisingly, the probable had a profound treatment effect. In fact, a treatment effect of 90% relative risk reduction. I'd be hard pressed to come up with any other secondary stroke prevention tool we have at our disposal that has a 90% relative risk reduction. So if you find those probables, this is as close to a slam dunk you'll find to what should be done for reducing the risk of stroke. The unlikelies, not surprising, don't get benefit, but the possibles were the majority of the patients. They were the largest population here, and they actually have a significant clinical benefit as well. And that's a 62% relative risk reduction. Again, that's even greater than what we're used to seeing with typical secondary prevention of any vascular disease. So that's the key, is either a high rope score or high risk PFO criteria puts them into the possible, and you can be very confident that you're doing the right thing for those patients as well. So just to, again, is 4% a high risk? These are just a table of data I put together that suggests, if you're treating a CHADS VASC of 2, if you're treating risk factors for lacunar stroke, if you're treating older patients, what are their risks of stroke? And to understand that 2 to 4% stroke risk is actually a pretty common stroke risk that we treat every day and do what we can to prevent it. The other point I want to make about closure and acting on this is the timing. When you find a patient and you think about treating them, remember this curve. And what this is this is the medical management arm in the reduced trial and the closure arm in the reduced trial. And they diverge very significantly in the first 6 months. That's where a lot of recurrent stroke events occurred. So, and this is from randomization. Just be aware of that when discussing with patients, when planning procedures, that certainly we want to give patients time to think about, process what they wish to do, but in reduce the overall number, again, it's a mixture of different risk profiles, but the overall risk reduction was profound, 77% relative risk reduction with PFO closure in their intention to treat analysis, the most robust statistical analysis, with a 2-year number needed to treat of 28. So that's what I want to kind of take away. So if you're treating blood pressure in the clinic, you're getting a 50% relative risk reduction for your patients. If you're lowering LDL, you're getting a 30 to 50% relative risk reduction. If you think an antiplatelet is reasonable for secondary stroke prevention, it's about a 20%. Treating diabetes with SGLT2 actually does not specifically have evidence for stroke prevention, but treating insulin resistance with pioglitazone also got about a 20% relative risk reduction. And then we compare our PFOs. If it's possible in that Pascal, you're getting 68, and if it's probable, 90%. So very robust, intervention. So in conclusion about the, taking an approach on selecting the right patient, it's a proven cost-effective therapy for properly selected patients. Screening with TCD is a highly reliable tool for the diagnosis. The size of the shunt should not necessarily influence your pathogenicity and may be underestimated, especially with TTE, and that ROPE score can assist in sorting the incidental versus the attributable PFOs and shaping a diagnostic conversation. In other words, don't be the clinician that says, oh, it's a small PFO, we don't need to do anything about it if the ROPE score is high. And also if the ROPE score is moderate, don't ignore a TTE or TEE criteria that shows an atrial septal aneurysm or a large shunt as being significant. So just one other comment about the economics of the treatment. This is my last point, and I just wanted to kind of talk about an analysis we've done, and there was a similar analysis done from the RESPECT group, so they're almost identical in their findings. But we basically created an economic model that considered the cost of treatment, in other words, PFO closure device and cath lab time and that medical cost versus medical management, which would encompass the global cost of the patient's care. And the question is, at what point does the healthcare system benefit from closure? And in our analysis, we found that it was about 2.7 years. Within 3 years, closing a PFO is more cost effective than medical management alone. And when we consider that those average age patients are 45, that disability, if it strikes them, it would have a severe impact not only on their quality of life, but their economic productivity for the years in their life when they're probably achieving the highest economic productivity. So that's where, again, just to kind of make sure we don't overlook this age myth, patients are typically early middle age. As a stroke of the young, I think is, as much as I'd like to say 45 is young, it's really kind of a stroke of the early middle aged, not of the young. So kind of takeaway point in terms of just awareness, being, thinking about this as much as we do other public health concerns. There are around 800,000 strokes per year in the US. We estimate that about 200,000 or a fourth of those are embolic strokes. Of those, there's going to be between 20 and 100,000 that are PFO related. If you're in a city, that means you're going to be having 80 to 400 of those patients a year just in your city, and maybe up to one a day. If you're in a large center and you're doing PFO closures, you really ought to be seeing patients come in for closure 1 to 2 times a week. But in reality, it seems like it's closer to 1 a month. And it does have a similar incidence in this age range of traffic fatalities. So wear your seatbelt, don't end up in that situation, and close the right PFO. And this is congenital heart disease awareness. I had no idea that everyone has I guess a way of promoting their condition now. So you can buy this t-shirt saying that you have a holy heart if you have congenital heart disease and wish to lump that in with this group. So with that, I'll pause and welcome any questions. And I think Robert is going to be able to help us with those questions.
First, I'd like to thank you for the talk today. I know this has been an exciting time in PFO and overall stroke management. So really appreciate the overall summary and the conclusions, really spanning everything from diagnosis even through the economics of PFO closures. I had as questions come in, so we have a few here. Could you talk a little bit about the evolution of, if there is at all, of the size of the PFO over time, whether that's both the size of the PFO over time and a little bit about post closure, how the PFO or the right to left shunt, or specifically the PFO, will evolve after closure?
Yeah, sure. I think that the first question is hard to answer. I don't know that we have good longitudinal studies that answer this. But I'll just put out there that there are some conditions that are associated with aging. So I guess that I'll frame the question as, do patients who have PFO experience a change in their shunt as they age? I would say that probably yes. And the reason is most often things that increase the right heart pressures, like obstructive sleep apnea. So as one ages, obesity itself and obesity contributing to obstructive sleep apnea causes an increased right heart pressure, and that makes what may have been even a potential space become an actual space, or an actual space become a more robust shunt. So that's just kind of my logical answer. I wish that there were longitudinal studies that I could cite that would say clearly that. The other thing we've seen is we've seen it, patients who have a PFO at one point clearly have a PFO come back a year or two later, and we don't see the PFO anymore. So if they've lost that weight, if they're using their CPAP, there's also at least a theoretical chance that they may not have that level of right to left shunt over time. So yes, always repeat your studies if it's been a while and the patient is not sure. The other factor, which it's not exactly PFO specific, but it is related to that longitudinal. Why are we seeing strokes at 45? Why if something's been there, might it pop up in midlife and not, in 18-year-olds? Why is this the case? And it's something that I think it has to do with the hematological changes that occur with aging, and maybe the somewhat higher risk of venous thromboembolism that occurs with aging. There's a natural decline in von Willebrand's factor with aging. And so at some point, the vulnerable patient is going to kind of reach that tipping point where they have just enough venous thromboembolism risk, they have just enough hematological risk and just enough anatomical risk. And for most people, that's going to be kind of in their 40s and not before. For the very healthy, the ones who are kind of somehow avoiding those risks by being healthy, they may be more like in their 60s. So you may see someone older than the clinical trials addressed, who just are chronologically older, but physiologically behaving more like someone 20 years younger. And we do consider those. We do consider those patients who are over 60. So that was the first part. The second question, you're going to have to remind me, Robert. I went on such a rant, I can't remember.
Is about the post-closure group
Oh,
that,
right.
that you've identified, and looking at the reoccurrence rate, or whether the PFO was completely closed, or how that evolves over time post-closure.
Yeah, that's a great question. So just the overall success rate of the devices is very high, greater than 95% success in terms of no significant shunt, meaning less than 10 bubbles seen after closure. And for most, it's zero. I think that it's 90% have complete closure, and 10% have some high degree of closure that would be considered clinically sufficient. And so what happens if they have a stroke afterwards? I think that's where you sort of have to go back and say, what did we miss? Because you've essentially excluded the PFO as the risk. We've had patients who have something like an apical akinesis that kind of wasn't necessarily recognized early on. We've had patients in the studies, I don't know all the details, but in the RESPECT trial, they alluded to 2 patients having vasculitis that were kind of under-recognized at the start. There have been, certainly dissection can be something that's hard to see if you're not attuned to it. So a patient could have an alternative diagnosis that simply went under the radar. That's usually the cause. I don't know that we've had patients have recurrent embolic strokes afterwards where we didn't find an alternative cause. You can have, of course, AFib from device closure, and they've not, at least in the studies, those patients who had AFib did not have recurrent strokes, but that would be the other thing to be on your list of concerns if you see that patient.
Right. So a question on kind of the Pascal criteria. I know the evaluation was done, and that's excellent work looking at additional risk factors. What are your thoughts on the role of Pascal or additional studies, maybe combining that with the BUBL study findings of the accuracy and the ability to identify that, and instead of using TTE criteria, using TCB, or would that change, or do you feel the results would be similar?
Oh, yeah, there's no scientific reason you can't just plug it right in, because what we saw in BUBL was that if anything, TT was underestimating, right? So if you're getting an accurate reading, then I would plug that personally right into the large shunt criteria for the Pascal classification. You're not going to be able to get the atrial septal aneurysm from the TCD, but if you do get the large shunt, personally, I would have no qualms about just using that as the Pascal classification.
And this is one personal question for me, I guess, is what are your, I guess, the big areas of scientific interest now? I know a lot has happened over the last few years, starting with the closure trials and now with the Pascal criteria. What unanswered questions are there out there within the identification of stroke or the management of ESIS in that area?
Yeah, no, there's two big ones for me, and I'll share with you the first. This is I'm in Houston, and we have Edward Albee, who wrote Who's Afraid of Virginia Woolf, and here's the Who's Afraid of a TIA. This is what I said early on, is we're not really looking to close patients with TIA, but as we have become more and more attuned to this as an etiology and as a cause, there are some striking TIAs, TIAs in which the patient has a cranial nerve deficit, TIAs in which the patient has no prior history of migraine, and you simply have a very strong inclination that the patient had an ischemic event. So I looked into the literature, knowing that this question comes up and knowing it's a question on my mind as well. And keep in mind that all the studies that reduce respect PC trial, they excluded they excluded TIA. So this data comes from other sources, but pooled with those patients. And if you look at this index event of TIA between the patients in the closure group versus the patients in the medical group, and you compare it to the index event of stroke, at least the point estimates, again, these are just a subgroup analysis, they're not going to have the same power, but the point estimate is similar, if not more robust in these databases for TIA patients versus stroke patients. So if you're looking for data, this is the best I could come up with to answer that question, but I do think this is the unanswered question. How do we select a patient who has a true ischemic TIA from someone who's essentially having a stroke mimic that we're calling a TIA? That was a real Achilles heel of the first study, the closure trial. And I think that's an unanswered question. The other unanswered question gets to the age. Again, most of the trials cut off at 60. We're doing post-approval studies looking at patients over 60. And what we're really finding is that it's a balancing act at that point between the AFib risk and the PFO risk. And the AFib risk tends to be transient, whereas the PFO risk is lifelong. So how do we balance that in a patient over 60 is a challenge. And I think that those studies will give us more information on the patients over 60.
Great, thank you. Another question came in about, I'll generalize it a little bit more about the identification of right to left shunt and other sources. I know there's evidence, in the heat of COVID with COVID producing intrapulmonary shunts, and again, I'll generalize a little bit further of non-cardiac right to left shunts, kind of that role within stroke management. and how you think about it within your care.
I try not to. That would be the, yeah, no, I think if we have a transpulmonary shunt, well, I guess there are non-PFO cardiac shunts. Of course, it could be a ventricular septal defect. There could be others, and I'll leave that to my congenital heart colleagues to determine what's relevant and what should or shouldn't be treated from a cardiac standpoint. But for the extra cardiac, yeah, if it's a large shunt, if we're seeing like what we would consider a large shunt on PFO, or if we're seeing the same kind of large right to left shunt without a PFO, then we are concerned that there's some kind of pulmonary AVM, and those patients will get a CT of the chest, and we may consider closure for those patients. For the patients who have this, it's usually the small right to left shunts with the transpulmonary. In those patients, I just medically manage them, and I don't even necessarily do a CT of their chest in those cases.
Great. Well, I don't see any other questions. I could probably go on forever on my own, but with that, if there's no other questions, I'd like to thank you again, Dr. Volpe, for the presentation today. Again, very comprehensive on everything from diagnosis through closure criteria, and looking forward to additional studies coming out in this area about the management of these critically ill patients.
Great. Thank you, Robert, and thank you everyone for participating.
Thank you.